So I believe you guys can hear from the room. Now I'm really honored to be joined here by some exceptional members of our team. Notably, starting from Professor Sophia, I hope I'm pronouncing the name correctly, ma'am. So she's a consultant anesthetist, and I think she's been supporting, supporting Dr. Sadhna's and team with her team. And I think we've got some, obviously, the young member of the team. So we're really honored to have them supporting this case. And I think, as I said, all of these people are exceptionally important for the success of our patients. And I think the man standing right next to me, Wasim, you all know him. He's been phenomenal as well, and I think part of Dr. Sadhna's success story. So Abir is here to present the patient. Abir, if you sort of speak up loud, I hope they'll be able to hear us.
Good morning, everyone. Starting off the course, we have a 13 years old female. She's had right upper quadrant gastric pain for the past 5 to 6 months. And she had an ultrasound that showed a dilated duct with stones in it, and her aerophils are also deranged as well, with a bilirubin of 2.07, alpha of 508. So we're going to be doing her ERCP today by Dr. Modi.
So, again, remember, as we discussed yesterday, it's all about teamwork, number one. And number two is the patient selection. So this is a young female, so with stones in a CBD and jaundice. So young, there are three things that we worry about in terms of the risk of pancreatitis, whether they're jaundice or not. She is. If the ducts are dilated or not. And thirdly, obviously, age of patient also has a part to play in it. So she clearly has an indication for this procedure. The imaging modality is only an ultrasound. We haven't done a cross-section imaging. Now, if you use the POCU criteria, so I guess on the basis of probability, I think it's the right decision to proceed. She's been consented for this procedure, and we are doing this under proper form. So I think the reason we wanted to demonstrate this to you so that at least you understand how it works here. And those who are here for the basic skills or the TTT, your job is to observe how everything is done here. Because if you're training or learning to train anyone in a new environment, it's important to understand the room setup, the scopes that you're using, the team that you're working with, because that is key to your success. Shall we make a start? I'm not sure, I hope you guys can still hear us. We can't hear you in the room. So if you have any questions, please do ask. We'll try to answer them as we go along. So we are using Olympus 190 scope. Again, make sure you're comfortable with the scope that you're using. Make sure you've got everything working, suction, air, fine, excellent, good. And we're using air or CO2? CO2, excellent. So I think that's also quite helpful. First, okay, so we're going to make a start. I know, I think.
Can we start?
Thank you. So holding the scope is important. I hope you can see the
Dr. Tehami, we cannot hear you.
It looks like they can't hear us. I don't think they can hear us. Can you hear us in the room?
Can you hear us?
Gee, we can hear you. Can you hear us?
Yeah, it's better now. So we are just on the history part. So if somebody could tell us what is the indication for doing it and it could start from the beginning.
Sure. So this is, see if your mic is working a bit. And can you sort of...
Can you hear us?
We can.
Oh, excellent. So Abhi, just give us the history again.
Okay, so this is a 32 years old lady. She came with gastric pain for the past 5 to 6 months. And we got an ultrasound done that showed CBD dilated at about 8 mm and stones in it as well. And then we also have derangement of LFTs. So that's why we're going to be doing her ERCP today.
So essentially, a young patient with stone disease, stone in the CBD, with jaundice, and the ducts are dilated on the ultrasound scan. So choledocholithiasis. Now, you may notice that I'm not putting too much air in, and I'm making sure that I'm keeping the stomach as empty as possible. So this lady is under propofol, she's not tubed, and you want to make sure you want to keep your anesthetist happy. And that is because you don't want to make this patient aspirate at the end of the procedure. So what we did, we are now in the stomach, and we were looking at the pyloric channel earlier. You want to have that sunset appearance. So right at the 6 o'clock of the position, you can see the pyloric canal going in, and I want to advance it, but I know I'm going to lose the view as I advance the scope. So the sun will set as I advance the scope. So I'm advancing it and making sure it goes in without any pressure. So I don't want to apply a pressure. Remember, no pushing, just advancing the scope as gently as I possibly can, without moving. So I need to have a bit of an idea. If I feel a resistance, which I do here, then I'm going to bring my scope back and again sort of readjust where is the pyloric canal. So I want to come back, have a look. I am still in the right direction. Okay. So I'm going to make an effort again, and I know obviously with the peristaltic movement, it is going to hinder my movement at some stage, but at other stages it should go in without much of a resistance, and it did. So I didn't have to do a lot of pushing. The other thing is, again, going from D1, D2, I don't want to use any force. I want to see what I can see, and then gently I'm going to advance. Remember, this is a scope which is a side wing scope, so my view is going to get lost as I advance the scope. But I want to bring the tip up, and I gently want to advance. And I know I'm going past the ampulla at this stage. So once I've gone past this area, then what I want to do is I want to just sort of bring the tip to the right with my small wheel clockwise. Now, whether you want to lock it or not, it's entirely up to you. Some people do. I generally do not tend to do this. I don't want to keep the wheel in this position, and I'm just going to gently withdraw my scope. Okay, there is a risk I may fall back, and that's what I believe is happening there. But at the same time, with the clockwise rotation, I've shortened the scope. At this stage, what I would like to do, I would like to screen, so to make sure that my scope is in a right position. So आप मुझे screen दिखा दें, please. Now I tend to prefer to keep the spine straight. बेहतरीन ज़बरदस्त spine को straight कर दीजिए, please. And what I'm doing is I'm gently bringing the scope back. So remember, what's actually happened is I'm gone to the right. So I've moved to the right, and that gives me. It's fine. इसको बस खाली जो आप इस पे इसको spine को straight कर दीजिए. Floss की भी patient ठीक है, floss की image पे कर दीजिए. हाँ जी. थोड़ा सा सीधा कर दीजिए. So at this stage, I'm gently bringing the scope back. I want to see where the papillary orifice is.
Dr. Tehavi,
Ji.
The audience and the candidates, they want to exactly know what maneuvers you are doing or making to achieve what you want to achieve.
True. So when you see this position.
And can you please start from intubation, because I think we have all levels gastroesophageal junction.
Sure.
How do you maneuver the scope in the duodenum?
Of course. So I think we'll go through those bits in each case, so you'll get an ample opportunity to understand exactly what we're doing. Please, obviously, we have to make sure that patient remains the center of our care. So apologies that you've missed out on initial bit, but let's focus where we are. So the scope is in the duodenum. Now, something important to remember, when you see this image that you see on the screen, and when you start seeing the part of the duodenum which you're not expecting to see, that means you are actually seeing the deep 3. Okay? And my scope is not in a position where I'm going to look at the papillary orifice with bit more clarity. So I'm going to bring the tip up of the scope. Now on the fluoro, I think my scope position is okay. I want to make sure I can locate the ampulla. So I'm going to bring the tip of the scope up. She's fine. That's fine. It's a good image. Don't worry. That's fine. Absolutely. That's fine. It's okay. It's okay. And the reason we wanted to do this is kind of a bit of a rehearsal, so that we all understand challenges that we may encounter when we start the actual teaching sessions. Okay. So anybody wants to sort of shout out where you believe the ampulla could be? Throw some flush, dijiyega, sir. So at this stage, when the scope is in the second part of the duodenum, my aim is to identify the papillary orifice or locate the ampulla. Okay, I'm going to gently bring the scope back. So I'm gently pulling the scope back, and I'm expecting to find the papillary orifice round about 1:12 o'clock position. Okay, so I'm right in front of the papillary orifice now. Okay, so all I did, I basically just brought the scope back. I pulled the scope back a little. Now, at this stage, it's all about position, position, position. So I want to get the ampulla in a position where it's going to be easier for me to cannulate. So remember, as we discussed yesterday, so advancing the scope a little, just a little, turning my shoulders toward the right, so that I can bring the papillary orifice at the top of the screen, ideally in the right top corner. So tip to the right. What it does, it should bring the orifice round about 11 or 12 o'clock position. Okay. Now I know some people do not like locking the wheel, but I would lock this small wheel at this stage. Okay. And I can see the papillary orifice right in front of me. Now, can I just have tons of flush, did you go? Flush, correctly, exactly, just face on. That's perfect, thank you. So now I'm going to get some of the air in, so that I've got a bit of a better view. So I'm face on with the papillary orifice. Okay, I'm going to do a little bit of a screening, so make sure my scope position is stable. Okay, now it does look like a bit of an unstable position, doesn't it? Okay, so it does look like a bit of an unstable position, and you may encounter this. So it may happen that sometime you are in a position where there's a risk that scope may fall back. So, but there isn't much you can do other than making sure that your scope position is as stable as possible, i.e. your position, you are comfortable with the scope. You've got the small wheel tip to the right, that is the tip to the right, and there isn't much movement happening with your body position and with your scope position. That's the best you can do at this stage. Any questions so far? I hope you guys can still hear us.
Audience, can you hear us? Are there any questions? I don't think so. There are any questions?
Okay, fine. In that case, what we'll do is we'll try to cannulate. So we are using, is it Olympus? Oh, sorry. So Cook or Boston? Microtech. Oh, excellent. Okay, so my elevator or bridge is locked. It's up. You can probably see around sort of 1, 2 o'clock. So what I'm doing is now I'm advancing the sphincter tome. Okay. Now I felt a bit of resistance, so I'm going to relax or bring the bridge down.
Okay.
Okay. And I'm gently going to advance.
Can we have the room view as well, please? Yeah, thank you.
So now I can see the tip of the sphincter tome out, and I'm just going to do a bit of a practice. Okay. Which direction my
Kindly
sphincter tome?
focus on Dr. Tehami's hands, please.
अगर आप मेरे hands पे focus कर सकें तो करिए. So
Thank you.
I'm keeping, remember, this position, okay, holding the scope with these 3 fingers, C and E movement, and I'm going to use this finger. So I'm just keeping it straight, and I'm going to insufflate only as and when I need it. Now I want to avoid contact here with the papillary orifice. Okay. Now, do you think my position is good enough for cannulation here?
So they're saying no.
No, exactly, because there's a risk that if I do so, I may end up advancing the wire into the pancreatic duct. So the direction of the CBD here is right at the top. So I need to go right at the, so if, as and when I go into this papillary orifice, I want to go towards the 12 o'clock within the papillary orifice itself. I don't want to go downwards towards the 4 or 5 o'clock position. So can I improve it further? If I advance the scope, I tend to lose the sight of the papillary orifice. So I'm going to bring this tip bit so that I can create some space between and the papillary orifice. Okay, I'm then going to advance it gently. Put some wide. That's enough. Perfect. So what I would like to do is in this situation to bring the scope little back and see if I can engage. That's it. Okay. Okay. So what I'm going to do is I'm just going to gently engage, and I'm going to advance this tip. So no, I'm not going in the direction I want to go here. Okay. So I'm not going to advance because I'm right at the lower end of the papillary orifice. I have to somehow or the other, so after engaging, I have to somehow or the other advance the scope so that I can bring the direction or improve the direction of the sphincter tome. Okay. There is a little bit of a risk at this stage that I may not achieve the direction I want to. So a little bit of advancing the scope. So I'm gone underneath it a bit, and I'm going to just gently advance the scope, gently advance the tip of the sphincter tome. Okay. Now this direction doesn't look too bad at this stage, so I'm going to try and see if I can advance the wire. G, please. No, so it's as you see. So Wasim Bhai didn't want to advance because as he did, actually there was a risk that we could have fallen back, and therefore he stopped doing this. So I'm going to advance a tip to the left a little and see if I can engage a little bit of a deeper cannulation at this stage. Okay. So let's advance at this stage further. Now stop there. So you can see this is not the direction I want to go in, and I'm not going to cannulate in this position. So I need to adjust the position of the sphincter tome. I need to bring it to 6 o'clock position. Okay. So how do I do that? Can I bring the tip of the scope to the left a bit? Okay. And at the same time, I'm going to advance the scope a little further. Okay. G, try no. G, So I think you may have noticed that Wasim Bhai also gave me a bit of a bow so that to improve my direction. Okay. So the wire doesn't want to go in this direction either. Okay. I'm just going to bring it back a bit, little bit. Advance कीजिएगा. नहीं जा रही. Okay. Just थोड़ा सा relax कीजिएगा इसको. यहाँ दीजिएगा. Okay, so we are not happy with the direction, so we're going to change the direction again. Okay, now in doing so, again, we have lost the position. So that's the position of the sphincter dome. There's a lot of pressure on the papillary orifice, and we don't want to do that, do we? So look at the small wheel. So I'm going to turning it to the right. Okay, turning it to the right. And we have fallen back, which is fine, because I wanted to improve my position. There was no point in putting a pressure on it and trying to get in. Okay, so we can clearly see the direction that it wants to go up. So it wants to go in this direction. That's the direction we want to go in. Okay, and we therefore would want to improve our trajectory, advance the sphincter dome a little, and see if we can bring the sphincter dome out a bit. Maybe PD direction. Okay. Yeah. बाहर पीछे लाए, थोड़ा पीछे लाए बाहर को. Okay. Advance करेंगे यहाँ पर. हाँ, बोल सर. नहीं. Sure. Okay. अब try advance करें. No. Okay. So that hasn't worked either, and the reason is, if you see it, I don't know whether you guys can appreciate or not. This is the direction of this. I don't think they can see the hand direction.
No,
so
we cannot see your hand.
Exactly. So that is slightly better. Okay. See, मुझे bow दीजिएगा. Give me a bow there. And advance there. No. Okay. Advance there. Okay. So okay. No. No. Okay. ठीक है. थोड़ा सा इसको रिलैक्स कीजिएगा. ठीक. अच्छा. Obviously that didn't work, so we're going to try one more time and improving our position and see. So this is a very good position as you see it there. So if I can go in there, it should. This is a really good position. I'm going to bring the sphincter dome back a bit, and as I withdraw the scope, what happens is I end up losing my position a bit. But I think that isn't a bad position. So at the top of the papillary orifice, okay, now not going down, I want to go up. Okay, but this is again hitting the side wall of the papillary of the ampullary complex, and that's where we are actually losing. Okay, it won't go. Just try there. नहीं हाँ wall से जा रही. Okay, that's fine. Just relax कीजिएगा इसको. So आप लोगों ने notice किया है what actually has happened now is, so ampulla is certainly more edematous than it was at the beginning. So we have attempted 3 times already. Okay, and so this is the direction. So see, this is the direction. That's the direction of the PD here. So from here, what I would do is maybe let me just go away from it a bit. No, the thing is, you don't want to go into the PD here. So we don't want to go. So it's actually happening. That's the direction of the CBD here. Okay. So what we want trying to do is we want to stay underneath the ampulla, okay, and want to advance the scope with sphincter tone a little bit. So as you see, the same by he's doing it. What he's doing is he's making sure he's bowing it so that we can get. So now we are actually hitting the side wall. We need to go in this direction, and we've not been. We can't do this here. Okay, try कीजिएगा. Okay, again hitting the side wall. So that's it. Try it there. That looks a much better direction. Advance it there. Screen कीजिएगा. Okay, stop screening, please. No, okay. What we could also do is we can inject small amount of contrast to delineate our position. Okay, just a small amount of contrast without putting any pressure here. Okay. Okay. Inject करें. जी screen कीजिएगा, screeners. जी inject करें small amount. Okay, stop. So underneath there's a filling of the PD, and so we are actually hitting. So there's a tiny stone that is right where the tip of the actual sphincterotome is, and I think that's what actually is obstructing the passage of the stone. So that's a very good image. Save this image for us. There's a tiny stone which is causing a blockage. Okay, so we are in the right direction. There's a stone which is blocking the papillary orifice. I hope you can see the fluoro image that we have taken. Okay, advance कीजिएगा, then wire screen कीजिएगा. Okay. Huh? Screen कीजिएगा. Advance कीजिएगा wire को. Nope. Screen कीजिएगा. That's it. So just save this image as well. Again, please. So there's a small stone which is right at the bottom of the, well, actually within the papillary complex. So I think that was obstructing it. And by advancing a little bit of a contrast, we could delineate what the direction was. So what we're going to do now is we're going to do a sphincterotomy. So once I've got the wire in, I want to make sure my scope position is now stable. So what I've done is I've got this small wheel to the right or tip to the right, and I make sure it's locked. Now I want to make sure I'm going to cut in the direction I want to cut it. Okay, so
Dr. Tehami, do you put dye in once the wire goes in before you do the cut, or you would just proceed with the cut?
So when we injected the contrast initially, we could see where the issue was. We could see there was a small stone right at the bottom of the CBD, and that actually confirmed the position. And I think that is good enough for us. And the reason is we've also know that from the imaging that we have already, that there's a one single stone with a dilated duct. Do we want to do a further cholangiogram for the diagnosis? Would it really help us? We can do that certainly. And I think in order to maybe demonstrate it more clearly, if you have not seen it, we could do that again. And I think let's just do that in this case. So maybe if you can aspirate first. So screen कीजिएगा, do it screen. So we are aspirating. Okay, that's it. Stop screening, please. Let's start injecting contrast. So we're going to do injecting the contrast and slowly going to bring it back. Okay, so I think the ducts are not really, stop injecting, stop screening. And exactly. So one of the other, you may or may not have noticed, there was a filling defect which tended to advance toward the common hepatic duct. And as we discussed yesterday, we don't want to send any small stones in the intrahepatic ducts. Okay? So ducts do not seem very dilated here. And I think we've already demonstrated a tiny stone or sludge right at the bottom of the CBD. So I think we're quite happy, and we're going to therefore going to do a sphincterotomy at this stage. Okay, I just want to make sure the cut direction is right for me here, and I think I'm pretty happy at this stage. So I'm going to do a bit of a sphincterotomy. So blend. Yeah, that's it. Okay. So we don't want too much of a tension because we don't want a zipper cut. Okay. That should be good enough. Okay, because it's a small duct, small stone. So debow, please. And now we're going to exchange. G, please. So if I can have a small balloon. Okay. So I want to make sure that scope position stays stable. As obviously you would see it on the cholangiogram images. Oh, I'm losing the wire. I'm so sorry, I completely forgot. I'm using a long wire. Apologies. Okay. So let's exchange. So this is where obviously you need a master working along with you. Otherwise, we could have lost the wire. So this is obviously a long wire technique, so we're going to exchange. So what you would want your colleague to do is to just exchange. So you in me out sort of wording or any wording that you are comfortable. कि आप अंदर जाइए मैं बाहर आता हूँ जैसे आपके लिए आसानी हो. Let's start doing it. So we're going to exchange. Start exchanging. Correct, exactly, because we know it's a small stone that we want to take out. We just want to make sure that there's enough. Exactly. So we are exchanging slowly. Okay, okay. Ji. So clearly, Wasim Bhai is a lot more confident here than I am in terms of the wire exchange. So I'm obviously trying to make sure the wire doesn't move, it remains on site. So it's built for more of a tactile feedback and also visual feedback that you require. So that blue-yellow margin seems to be quite steady as we're exchanging.
Nadeem? Nadeem, was there a stone in the duct?
So there was that's what the imaging report was initially. And then we also, when we did an initial cholangiogram, we felt there was a small, tiny microlithiasis right at the distal end of the CBD. So I've now got the wire, and I'm going to make sure I hold the wire. That's what my initial impression was, and I hope if we have saved that image, which we can review again and demonstrate to the team where we initially felt the stone was. वो आप पहली वाली image दिखा सकते हैं? Can you show the पहली image जो सबसे जिसमें हमने the image that we took before advancing the wire. That's it. Yeah. Okay, that's it. Thank you. So आपके पास wire है? You got the wire? Okay, and I'm going to advance the balloon. What size balloon is this? Okay, that's fine. Let's just we'll do a. So this, what do we feel the size of this duct is on the initial imaging? Remember, it's the duct caliber or is not bigger, larger than the scope itself. Correct, exactly. So it's not more than it's about 10 millimeters, it's not more than that. And therefore, I think the stone, a balloon size 12 is more than sufficient that is required. Okay, so you will keep on advancing, making sure that we are holding the wire, and as we advance, what we do is we don't want to lose the wire at this stage. So as the accessory of the balloon wants to come out, we want to stay close to it, and we gently want to advance it. Okay. G. Okay, so gently making advance. So what we can do is we can size this sphincterotomy at this stage. So if I can have it to 10 तक ले जाइए सीम भाई. जी. Excellent. So screen कीजिएगा. That's it enough. Thank you. Huh? Okay. Okay. Balloon down, please. दोबारा ट्राई कीजिएगा सीम भाई. Balloon up. So I'm gently withdrawing the balloon, and at this stage when I am right at the lower end of the duct and when I feel a resistance, you may want to look at my fingers. I'm not sure if they can hear us in the room or not. Balloon down, please. Okay. Screen कीजिएगा. Okay. See, may stop screening, please. Just contrast it. Ji, please. Without screening, we don't need to screen this. That's enough, thank you. अब आपने देखा कि all the balloons, bubbles came out. That's a Khalid Weiss technique where I think it's ensure that there are no actually residual stone, because sometimes you can misinterpret stone bubbles as stones. Okay, so balloon up to 12, please. Okay, inject contrast, please. Just save that image for us, please. That's it. Ji. Stop. Correct. Yes, so that's exactly what I said, using the Khalid Weiss technique, because right at the top of the distal duct. So I think that it looks to just save this last image. So I think the duct is pretty clear. So we are going to call it a day. Yep. We would regard that as a clear duct at this stage. In an ideal world, we want to do 3, but I think we've seen it initially. There wasn't any convincing in comparison to what we felt earlier. So I think I would call it a day here. So Inko, obviously she's had a whole calls for this year. Thank you so much. Thank you very much. So we'll stop it there. So before we withdraw the scope, I'm not sure they can hear us in the room. I doubt it. Just take it.
Can you hear us?
अब तो साथ चल जी. Okay. Well, I'll say initial contrast injection in the PD without any.